I am Roberto Bolli from the University of Louisville, and with me is Dr. Thomas Povsic from Duke University. We just finished attending a very exciting session on stem cell treatment for cardiac and peripheral arterial disease.
So as you said, Dr. Bolli, it was a very exciting session, very good attendance. I was wondering if you had some thoughts. The first couple trials centered on heart failure. Two of the trials looked at cell therapy in patients who were undergoing LVAD implantations, and then the third, Josh Hare's work in the TACT HF trial. I was wondering what your thoughts were first on the LVAD trials, perhaps.
Yeah, sure. So there were two studies on LVADs. These are very exciting because these are the very first studies of stem cells in patients that receive an LVAD. And these are the patients who really need help the most because, as you know, their prognosis is quite grim. And so they're a logical target for stem cell therapy. One study was a very small study that ended up enrolling only 6 patients, in which the goal was to compare the effect of CD34 positive bone marrow cells with CD34 negative cells and unfractionated mononuclear cells in patients that underwent VAD placement as a bridge to transplantation. So this was a unique population because basically it was possible to harvest the heart at the time of transplantation and look for the histological effects of stem cell transplantation. And the conclusion of the study was that, quite surprisingly, the injection of CD34 cells did not increase the number of capillary vessels or any kind of vessels in the heart. In fact, there was a decrease in vascular density, and also there was no significant change in fibrosis in the areas that were injected with CD34 cells. This is a small study, and the problem is that there is quite a bit of variability in the histological assessment of capillary density and fibrosis in these hearts. And so to compare, as the authors did, one injection site with a non-injected site or with a saline-injected site is very difficult.
And the other study looked at an allogeneic mesenchymal precursor cell that was implanted in patients
Yes.
with LVADs as well.
The other studies was conducted by the cardiac surgery consortium sponsored by the NIH, CTSN, and assessed the effect of mesenchymal precursor cells on patients undergoing VAD implantation. It was a mixed population with roughly 60% of patients having non-ischemic cardiomyopathy and 40% ischemic cardiomyopathy. The cells were given intramyocardially at the time of VAD implantation, and then patients were followed up for 1 year. The dose of cell was 25 million cells, and the patients were randomized 2-to-1. The primary endpoint was, since this was a phase 1 trial, was safety and feasibility, and there were no adverse effects of stem cell injection of any kind. In terms of efficacy, at 90 days after stem cell injection, there was a higher proportion of treated patients that could be weaned temporarily for 30 minutes as compared to control patients. 50% of treated could be weaned versus only 20% of controls. It was not statistically significant because of the small sample size. At 12 months, this difference disappeared, and both controlled and treated patients were similar in terms of the ability to be weaned. Ejection fraction during weaning also was not significantly improved by treatment. So it is a small study, but nevertheless important because it suggests that injection of bone marrow cells is safe and feasible, and may increase the ability of patients to be weaned from VAD, from their VAD. And so I believe that these data support further research in this very sick and very high-risk patient population.
Yeah, it's a very interesting population, as you pointed out. As the investigators indicated, it's a unique human laboratory
Yes.
with our ability to get tissue back, which
Yes.
is something that offers us a unique ability to do translational work in this regard.
Yes.
But it's also interesting, these patients are extremely sick, and especially for autologous sources, there's some concern that their stem cells may actually not be as efficacious as they are in younger patients or
Yeah.
less sick patients.
Hence, I believe one of the attractive features of this study was that cells were allogenic, were obtained from a single healthy donor, and so they were not subjected to the limitations caused by the morbidities of these patients.
So switching gears a little bit, the TACT-HF trial was a more conventional heart failure trial. I wondered what your thoughts were on that one.
The TAC-HF trial was very important in my mind. It was a study in patients with ischemic cardiomyopathy. Ejection fraction was in the low 30s. Most patients were in New York class 2 or 3. And the goal was to compare mesenchymal stem cells with unfractionated bone marrow cells in this group of patients, and to determine which of the two cells could have greater efficacy in improving function. The cells were given by transendocardial injection, and patients were then followed up for 1 year after administration. The results showed that compared to placebo, both mesenchymal stem cells and unfractionated bone marrow cells improved the quality of life as measured by the Minnesota Living with Heart Failure questionnaire. But the mesenchymal cells seem to be superior because they also increase the 6-minute walk-in time. They increase the maximal oxygen consumption and decrease the scar size by approximately 30% with a concomitant increase in viable tissue, as well as improving regional function as measured by MRI using strain analysis. So these data are fairly encouraging in terms of using mesenchymal stem cells given transendocardially to treat patients with chronic ischemic cardiomyopathy. And clearly now the next step is to conduct a larger study using this cell type.
Yeah, very interesting study.
So there was a very interesting study using GM-CSF from Emory that had some interesting results.
Yeah, so this was a trial of patients with intermittent claudication, single center study. They managed to enroll, I think it was 159 patients over just over 2 years. So really, as you've had experience with studies like this, you know that's quite a task to enroll this many patients. And showed that there was, in the intention to treat analysis, not a statistically significant, but definitely numerical increase in walking time in the patients that were treated with GM-CSF. And in the per protocol analysis, this actually reached statistical significance. So, you know, intriguing data. GM-CSF is a little bit different than G-CSF, was given chronically. The patients self-injected themselves at home. So a really interesting approach that certainly would warrant further study down the line.
And the data were tantalizing because they almost achieved statistical significance on an intention to treat, but they clearly achieved significance on a per protocol analysis.
Right.
And one has the feeling that with a larger sample size, they probably would have had a positive primary endpoint.
Yeah. And also interesting that they treated an intermittent claudication population, which hasn't been targeted with stem cell therapy as much as chronic limb ischemia population in the PAD area.
There was also a 1-year follow-up on the TIME trial conducted by CCTRN, which was very convincing, I thought. What was your impression?
Yeah, so there was 2 additional trials. The TIME trial, like you talked about, presented their 12-month follow-up. They had very complete MRI-based follow-up through 12 months, and we'll also be collecting this data at 2 years. So we will have a very nice database of MRI structural and functional analysis of patients who have had an anterior myocardial infarction, which I think will be very useful for planning research in the future. Given that they didn't see a benefit on ejection fraction at 6 months, it's not surprising that they didn't see any benefit at 12 months, and the MRI parameters between the 2 groups look very similar. And so we're really left puzzled in the field about the efficacy of unselected bone marrow cells in the acute MI setting, and we're all waiting now the results of BAMI, which, as you know, just started in Europe, which is a mortality trial, which I think will definitively answer the role of unselected bone marrow cells in this patient population.
So there had been some suggestion that the presence of heparin in the bone marrow may account for the failure to see an effect, but clearly that is not a factor because the amount of heparin that was used was minimal and not sufficient to impair stem cell function as shown by other investigators in other models. So it is puzzling that there was an effect, but the study was, I thought, was very convincing, was very rigorously conducted, and the data were very unequivocally negative in the sense of not showing an effect. And finally, there was a study from Austria looking at the effect of cytokine administrations in patients with STEMIs, which was quite original in the sense that I've not seen that combination before.
Yeah.
Right?
So this trial actually looked at the combination of G-CSF with sitagliptin, which is a dipeptyl peptidase 4 inhibitor. And DPP4 is responsible for the breakdown of SDF1. So the investigators postulated that by preventing breakdown of SDF1, they might increase stem cell honing to the myocardium and in combination with G-CSF improve ejection fraction. And they have convincing animal models that suggest this is the case. But unfortunately, it didn't translate into clinical practice. As you know, it's been difficult to find therapies that improve outcome after acute myocardial infarction, despite a plethora of therapies that have been studied in preclinical models. So unfortunately, this didn't seem to translate into clinical effect either.
Yes, it was a large population of patients, if I recall, but the problem was the baseline ejection fraction was quite high. It was 51 or 52%. We now know that when baseline function is normal, it is very difficult to show any beneficial effect in terms of at least ejection fraction.
Yeah, I think there's a lot of excitement in the field, a lot of trials going forward. And, I think that one of the things that the CCTRN was really designed to do was invigorate stem cell research in the United States, and I think stem cell research in the United States is very alive and well.
Yes, there are many questions that remain to be addressed. I think my take-home message from this morning's session was that mesenchymal stem cells are very promising in patients with heart failure, and that GM-CSF administration is also promising in patients with peripheral arterial disease.
Well, thank you, Dr. Bolli, for taking time to review these studies with me, and it was a pleasure, and we look forward to hearing more about stem cell therapy at future meetings.